How are you?
Thank you. Hi, how are you?
Hi, Fen.
Yeah, hi.
Yeah, I cannot see you.
Sorry, I've taken off my video by mistake. Sorry about that.
Okay, good. Long time.
Yeah, it has been too long. I need to come over and see you.
This COVID is giving us a chance to be having more face-to-face events now. So
that has made life a lot easier. So yeah, I think the meeting is at the same time as the we're having a meeting as well, aren't we? But I need to do this. Do we know what the format is? Are you going to introduce me, or am I just going to start?
Oh, okay.
What I will do is, if you present your slides, I will then introduce you with your bio, and then you can go. Then again, just go from there.
So Ola is chairing it. So Ola, please go ahead and give the chair.
Okay, just present your slides, and I'll start doing it.
So I need to share my screen.
Yes, please. Okay, good afternoon. Good afternoon all. I hope you're all well. This is the last week actually of the lectures we were running. Just 2 more left. So we've got today Professor Fenella Kirkham, who is a professor of pediatric neurology. She focuses on neurocognitive complications in sickle cell disease, collaborations with hematologists in England, Europe, US, Middle East, India, and Africa. She's got some very interesting information here for you to learn about, still that focuses on TCD as well. So if I'll just let her have the floor. Thank you.
Thank you very much, and thank you very much for inviting me to speak. I'm very honoured. I'm presenting on behalf of a lot of colleagues from all over the world, and in particular a number of psychologists that I've been working with for a long time, as well as pediatric hematologists and paediatricians across the UK, including Dr. Anusa and various other colleagues. And it's also been an enormous pleasure to be part of the ARISE consortium, working with team members, particularly recently from Nigeria, who've come to join me. So I'm going to start by showing everybody the historical problems with stroke in patients with sickle cell disease. And this is data from the cooperative study of sickle cell disease. The first author was Kofahina Frimpong, who very sadly died last week, having made an enormous contribution to academic work in sickle cell disease, as well as looking after patients both in Philadelphia and in Ghana. And I very much acknowledge his contribution. This paper was absolutely fundamental to understanding the natural history of stroke in sickle cell disease, and you can see that immediately from this survival curve that patients with hemoglobin SS are affected younger and more than people with the other genotypes, and patients with SC disease do have problems with stroke, but not until a little bit later. And people with the thalassemias may be somewhat protected, these heterozygous for hemoglobin S and thalassemia. And this figure was also in Koff's 1998 paper, and it shows the hazard function by age for ischemic stroke in the yellow full line, and hemorrhagic stroke, the red dotted line. And what is still very poorly understood is that in patients with hemoglobin SS, there's a very high rate of stroke in young children. and it tends to fall in adolescence, and then goes back up again in middle age, and then onwards. Obviously, survival is a lot longer now than it would have been, and the stroke, there's a cumulative risk of stroke. Hemorrhagic stroke peaks in the mid-20s to 30s, but it does happen in children, and I will be showing you some examples. So just as background, I'm going to talk about clinical neurological syndromes that we recognize. As you'll see later, stroke prevention is now possible, but there still are patients who are having acute neurological syndromes. And I'm going to start with arterial ischemic stroke because it's the best recognized. It happens in sickle cell disease, and it also happens in other anemias. Actually, iron deficiency is a risk factor for stroke in childhood in the general population, and also spherocytosis is a risk factor. It's thought that at least one of the additional risk factors in sickle cell disease may be the hemolysis, and that's why I've shown you somebody with jaundice. And everybody would probably recognize that this MRI scan shows a stroke. There's a large area in the middle cerebral artery territory on one side, which is a different density. It's white on this MRI scan compared with the rest of the brain. And if you look on the right-hand side, that's the circle of Willis, absolutely crucial for brain health because it shifts blood from one side to the other, otherwise we'd all fall over. But you can see very importantly that the middle cerebral artery on the same side is completely blocked. So that's a classical stroke in a young child. Tragically had been completely well previously and top of the class and was left with a dense hemiplegia, and I will show you her later. What about transient ischemic attacks? Well, I first met this boy when he was 3, when he was acutely ataxic, and we thought he had a posterior transient ischemic attack with dizziness and visual symptoms and ataxia. He had a low velocity transcranial Doppler, and we didn't do anything about it, partly because it was before the STOP trial, partly because he had a low TCD. And he had progressive cognitive difficulties and then had a dense left hemiparesis at the age of 16. And you can see on the right-hand side that there's an internal carotid artery here. I hope you can see my my mouse. There's an internal carotid on this side, but no internal carotid on the other side. And he had a complete occlusion. And one of the things I think it's worth emphasizing is that in children, we really mainly look at the intracranial arteries for lots of reasons. The pathology is mainly there, and we can screen for this disease. But actually, we also have neck vessels. We have not been as good at looking at for that until recently, and it's also probably a major problem in the adults. What about the adults? Well, very little data. You can see that from the epidemiology, strokes are still happening in adults. This is a man with hemoglobin SC who I met at the age of 35. He'd been completely well, working hard, had sudden onset of hemiparesis, luckily quite a small infarct, and he made quite a good recovery. The only risk factor that I could find was that he snored a lot, and he had I insisted that he had a polysomnogram, and he had obstructive sleep apnea on that. I'll come back to that later. Okay, so that is perhaps the classical stroke that all doctors, nurses, general people in the general population will recognize. And in fact, that's really what recommendations like the FAST recommendations are about, and that's on television, certainly in the UK and probably in the rest of the world. And my sister-in-law actually had an acute stroke, and my brother realized what was happening, and she's made a full recovery because she was thrombolyzed. So those are classical arterial ischemic strokes, and everyone should recognize them because there's treatment available. However, People with sickle cell disease also have other presentations, and next I'm going to talk about acute severe headache, usually hemoglobin SS. And the first thing you should think about if somebody has their first acute severe headache is, have they had an intracranial hemorrhage? That can be a subdural, possibly after minor trauma. It can be intracerebral, and this patient had a completely spontaneous acute intracerebral hemorrhage, and it can be subarachnoid. The times I've seen that have mainly been after chest crisis, when transfusions happen very quickly. Particularly for the spontaneous intracerebral hemorrhages, cerebral aneurysm must be excluded. And on the left is an arteriogram showing the aneurysms here, and on the right is an MR angiogram also showing the aneurysm, very small at this stage. The problem with screening with MR angiography for aneurysms is that we don't actually know what to do about them if they haven't already burst. So I think we need to watch this space, but certainly if you do not have sickle cell disease, there's no recommendation to treat an asymptomatic aneurysm at the moment. We do sometimes see hemorrhage in patients who've already had an ischemic stroke, and moyamoya may, and I'll talk about that a bit later, but moyamoya may be a risk factor for that. This is a gradient echo scan from Edward Kija's study from Tanzania, and you can see that there's a white abnormality here on the MRI, which is the ischemic stroke, but a larger area of hemorrhage around that area of ischemia, and that is hemorrhage on an MRI scan, on a gradient echo MRI scan. In that study, we did actually look for microhemorrhages and didn't find any apart from this patient who was already symptomatic. And then, even more importantly, I have also seen quite a few patients who've had hemorrhage. This patient had a subarachnoid hemorrhage and then has ischemia, and that often again happens in time of chest crisis. And my strong recommendation in order to get a good outcome and prevent further recurrence after an acute subarachnoid hemorrhage is, first of all, if you have a patient with a chest crisis, please do not transfuse them too fast. You obviously need to transfuse them, but I don't think it needs to be fast. And if you have got a patient with a subarachnoid hemorrhage, the prognosis can be excellent. However, they may well have vasospasm in the large vessels. And this patient actually had watershed ischemia throughout the brain, and has actually got major cognitive problems, although he's ambulant. And my strong recommendation is, if you have overtransfused a patient, the blood pressure's gone up, don't reduce the blood pressure quickly. You need to take at least 48 hours to get the blood pressure down. So in a first acute severe headache in sickle cell disease, you need to manage this as a neurological emergency. You need urgent neuroimaging, and you will need a neurosurgeon. So you need transfer to a neurosurgical unit, and across the world there is usually good enough neurosurgery. If there is an infarct as well, you probably need an emergency transfusion. And only if there's no hemorrhage or infarct should you consider this to be migraine. Migraine is a diagnosis of exclusion in sickle cell disease. It's absolutely fine to consider it migraine if it's the 10th episode and it sounds like typical migraine, but if it's the first episode, it's not migraine until you've excluded hemorrhage. What about acute seizures? Well, it's well recognized in children that can be presenting the presentation of acute ischemic stroke. This child actually turned up in Southampton where I was working. We have very few children with sickle cell disease, but this patient came at the age of 18 months, recently immigrated from Ghana, and had a cerebral abscess, somewhat to my surprise, and did extremely well after neurosurgery. Please think about venous thrombosis. This is a patient that I looked after when I was at Guy's and St Thomas's in the 1980s, long before Bubba was there, probably before most of you were born. And this patient had pneumococcal meningitis at the age of 3, and then subsequently had very severe seizures. And she'd actually had a venous sinus thrombosis. The blue arrow points to the empty delta sign. Interestingly, I looked after her for a long time, and eventually she did respond to the anticonvulsant tiagabin, not used very much, but very effective in her. So I think one of my other points would be is if you have seizures in the context of sickle cell disease, patient should be treated exactly the same as anybody else, and you do need to change anticonvulsants. Very few patients are now completely intractable. This is a straight sinus thrombosis, also a venous sinus thrombosis in a child who had hemoglobin SC disease, who'd had unexplained hydrocephalus in infancy, and then presented with seizures. And tragically, before we realized what was happening, he developed massive cerebral edema and died. And then there's a posterior reversible leukencephalopathy patient, again, commonly after chest crisis, presenting with seizures. And this patient also developed chronic epilepsy after that. Again, if the blood pressure is high, you will need to reduce it, but slowly. Is the prognosis for reversible posterior leukencephalopathy. It's a good reason there's a reversible in there. Prognosis for just having the white matter problem. Prognosis if you've had an infarction because the blood pressure was dropped too quickly is very poor, and blindness may well result. And this is another patient who had a facial infection and seizures. You see very clearly that this patient has also bilateral watershed ischemia, and that was related to dropping the blood pressure too quickly. Importantly, this patient did not have any motor deficit because the motor parts of the brain are not affected, and he an identical twin, and he went back to mainstream school, but he'd lost 30 IQ points. We a prospective study, and so he had a cognitive hit, and I think that's quite an important message. And I'll be talking a little bit about transcranial Doppler in a minute, but the other thing is that children with seizures may have had a stroke already, or maybe at high risk of a stroke. So transcranial Doppler is an important part of management. So if you're looking after a child with sickle cell disease who has a first acute seizure, you do not assume that they have a febrile convulsion, please. It may be a presenting feature of stroke, either arterial or venous, or of posterior reversible encephalopathy syndrome, or of cerebral abscess. You must have an emergency MRI for a first seizure if there's a Glasgow coma score less than 15. It can be a CT in the first instance, but MRI is preferable because it's easier to pick up posterior reversible encephalopathy syndrome with MRI. TCD is recommended as well. Epilepsy is 10 times as common as the general population, but seizures can be the presenting feature of much more serious pathology. And if you want to be preventing more serious pathology, you must do imaging at the time of the first seizure. Okay, why do neurological problems cause so much of a problem in sickle cell? One of the major issues is that if you've had a stroke and you may have presented with hemiplegia or an acute headache or seizures, if you've had a stroke, there is a very high incidence of recurrence without treatment. And this is data that we're putting together from very early on the original POWERS data. One of my students, Elizabeth Angiobi, has actually pulled together for me. And you can see that pretty much 40% of people with sickle cell disease who've had a stroke have a recurrence without any treatment, if there's no treatment. However, although transfusion does reduce the recurrence rate, it certainly does not abolish it. And that's particularly true if you have moya-moya. What is moya-moya? Moya-moya is basically severe stenosis, i.e. narrowing or complete occlusion or blockage of the terminal internal carotid artery and or the proximal middle cerebral artery with collaterals. And the moya-moya is basically the collaterals, and the reason that it's called moya-moya is that the collaterals look like a puff of smoke, and moya-moya is the Japanese for puff of smoke. What it really means is if you've got very basically got a touch of tight stenosis or occlusion, that the brain to the artery that's blocked is very short of oxygen, and the collaterals have come up in order to deal with the lack of oxygen. They're a compensatory mechanism, but they're usually not enough to compensate. Now, this is Barbara Noosa's data looking at risk factors for recurrence, and Scowthorne et al. Had already shown in 2002 that if you were more likely to have a recurrence if you had a stroke completely out of the blue. If you would, rather like my first patient, if you were completely well, doing brilliantly at school, and you then have a stroke, then you're more likely to have a recurrence. And in the context of another illness, like say a chest crisis, renal difficulties, whatever, then actually you're less likely to have a recurrence. However, there's still quite a high rate of recurrence. And this is our data Bubba presented some years ago, repeating Scowthorne's analysis and showing that that those with a no prodrome had a higher risk of recurrence in the London data as well. And that is particularly true if you have the moya-moya collaterals, again confirming the data from Dobson showing that moya-moya was a risk factor for recurrence. However, there are plenty of patients who at high risk of recurrence who have neither prodrome nor moya-moya. Okay, now I'm not going to say very much about what to do here. Most patients who are at high risk of recurrent stroke are on chronic transfusion programs, and bone marrow transplantation is an option for this group of patients as well. I'm not an expert in that, but good results are had in that situation. The risk of recurrence does seem to go down. What I am going to talk about is the very important data on primary prevention of stroke and sickle cell disease. And Bob Adams takes the credit for setting data initially in the cohort showing that screening with transcranial Doppler predicted stroke risk. On the left here is a transcranial Doppler velocity of 200 centimeters per second, and that predicts a 40% risk of stroke over a 3-year period. Whereas on the right is a conditional velocity of 182 centimeters per second, which predicts a 7% risk of stroke over the next 3 years. So this is a high risk of stroke, and Dr. Adams subsequently did was to show that you could reduce this. How do you obtain a transcranial Doppler? Well, you certainly need a bit of practice to be able to do it. I'm currently remote training in a number of countries, including Saudi Arabia, for the Hope Kids 2 study of voxelotor. And you need a flexible wrist. You need to be able to put the probe on the head and get a signal, and be prepared to be patient. And then it's pulse Doppler, so you track along the artery and you can get good signals. And this is Bob Adams himself and his son, age 7, I think the child's now 40 something. And you can see that it's relatively easy to put the probe on, not always that easy to get a signal, but we have been able to train people in a number of countries remotely to do this during the COVID-19 pandemic. And this is me doing a transcranial Doppler. This is an old machine, a little bit more portable now. That's actually the girl that I showed you, the first girl with the big stroke, who has a who's holding her right arm because it doesn't work very well. And this is with the transcranial Doppler. There are important factors that affect transcranial Doppler. First of all, if you're asleep, the velocity tends to go up, so you must be doing it awake. Secondly, there are gender differences in several studies with high velocities in females, possibly because females tend to have slightly lower hemoglobin. And you can see in the bottom left corner here, hemoglobin is an important risk factor for having a higher velocity. The lower the, and that's actually not in patients with sickle cell disease. That's data from Kenyan patients with iron deficiency. And then very importantly, having a high entitled CO2 increases the velocity as well. And you can see in the top right hand corner, if you overbreathe, the velocity comes down. And if you have a higher CO2 because you're not breathing very well, you're doing breath holding, then the CO2 goes up. The velocity goes up. There is a normal range for again, this is data from Kenya from the 1990s, working with Charles Newton, and you can see that the upper limit of normal is about 140 centimeters per second. So patients with sickle cell disease who have velocity 140 centimeters per second are in an abnormal range, or are in a non-normal range. I'm going to call it non-normal for reasons we'll see in a minute. Okay, so this is this shows the risk of having a stroke if you have a high velocity. What you're looking at here is the pink range is the velocity range where you have a normal velocity between 70 and 150 centimeters per second, and particularly if your MR angiogram, which I'll show you in a minute, is completely normal, you really do have a low risk. If you have higher velocity than 150, the risk starts to go up, and above 170 centimeters per second, which is conditional, between 170 and 200 centimeters per second, the risk is 7% over 3 years, and above 200, it is 40% over 3 years. But if you also have an abnormal MR angiogram, the risk is much higher than that. I think particularly with this group, most people would be doing an MR angiogram in that situation. If you have a low velocity, then you may also have significant cerebrovascular disease, a little bit like the patient I showed you with the TIAs when he was 3, he went on to have a stroke when he was 16. So I think that patients with low velocities should be considered further. How frequent are high velocities? Well, it does depend a bit on where you are, and also probably on time frame. We looked at the London data in the 1990s and 2000s, and basically we had about 5% of patients, whereas at that time 10% in the US in Adams studies, but Julie Cantor's recent data puts the figure more like 3 to 4% in the US. And there in the Middle East, where there's a much higher hemoglobin F in many of the patients, the prevalence of abnormal transcranial Doppler is lower. Okay, why does this matter? Well, Bob Adams, having shown that the risk of stroke was very high with high transcranial Doppler velocities, went on to do an NIH-funded trial of blood transfusion for velocities over 200 centimeters per second, randomly allocating to either blood transfusion or no treatment. This was an absolutely amazingly effective treatment because there was a 92% risk reduction, which anyone running a controlled trial would be absolutely delighted to see. And then Robert Adams then did the STOP2 trial, which randomized patients who'd been transfused for 3 years to either stop transfusion or to continue transfusion, and basically the patient continuing transfusion had no strokes, whereas the patients who stopped transfusion did continue to have strokes. And this slide is taken from the American Society of Hematology guidelines, and I do commend this guideline to you. I've sent it out. It's actually free online, but I've sent it out to you, and I think it's actually very useful from your point of view, to look carefully at those. I showed you my patient who just had a chest crisis, who had the high velocities, and this just shows you that in fact he did have an abnormal MR angiogram. You can see that there's almost no signal in the middle cerebral artery on the right, corresponding to the velocities of 200 centimeters per second, and on the left the MR angiogram is not completely normal. It is very important, I think, if you've got a patient with very high velocities or a patient who's already had a stroke, it's extremely important to actually obtain an MR angiogram if you can, because it does stratify risk of having a first stroke if you've never had one because you're being picked up with high velocities, or of having a recurrent stroke if you have moya-moya. And one of the things I forgot to say when I was talking about moya-moya is that as well as thinking about bone marrow transplantation, revascularization, in other words, putting more blood flow with a vascular procedure through the scalp is an option. And I sent you the supplement to the guidelines paper that I've just shown you, and the available data on revascularization are in that supplement, and I pulled that together with Laurie Jordan. And these are the grades of arteriopathy. You can see in sickle cell disease on the top left is normal. Below that, number 1, mild arteriopathy. You can see it's not quite normal. And then grade 2 is more abnormal, and grade 3 is almost occluded, but there are no collaterals in this patient, so I would not call that moya-moya, although the occlusion is pretty obvious. And this just makes a point about the low velocities. Some of the patients with low velocities have a normal MR angiogram, and that means that the transcranial Doppler was probably inadequate, either because the bone was too thick or because the operator couldn't find the signal easily enough. Sometimes people are getting the posterior cerebral, not the middle cerebral. However, some of those patients do have occlusion, grades 3 and 4, as you can see here. Oops. Not sure why that won't go. Oh, there we go. Okay, so transfusion is a very massive burden and actually very expensive. And there's been a lot of interest in whether hydroxyurea would prevent stroke. The Twitch trial, led by Russell Ware, randomized patients who'd had a year of blood transfusion for abnormal transcranial velocities to either having hydroxyurea or carrying on with blood transfusion. And this was basically a non-inferiority trial. And the study showed, it was published in 2016, the study showed non-inferiority. So many patients in the USA and Europe have now been switched on to hydroxyurea after a year of blood transfusion for abnormal transcranial velocities. What about using hydroxyurea as primary prevention? Well, data have been gradually accumulating which show that hydroxyurea does reduce velocities in sickle cell disease, and this is a pooled analysis, forest plotted with pooled analysis, again taken from the 2020 ASH guidelines, and you can see that the overall pooled analysis shows a reduction of about 20% overall in velocity, and that probably makes a lot of difference. Michael DeBown has been working very hard in northern Nigeria with Shehu Abdullahi and Bintu and in Kano and Kaduna, and you can see that they initially did a spin trial. Najiba Galadansi is the first author on this, and this basically used moderate fixed dose hydroxyurea, which is 20 milligrams per kilogram, and showed that the transcranial Doppler velocities came down with the hydroxyurea, and in fact they couldn't, this was not a randomized trial, they couldn't really show that there was a reduction in stroke, but they then went on to do a randomized trial of 10 versus 20 milligrams of hydroxyurea for transcranial Doppler velocities over 200 centimeters per second in the spring trial, we used 10 milligrams per kilogram because we weren't allowed to use a placebo, but it was thought to be a placebo controlled trial. But in fact, 10 milligrams per kilogram prevented stroke as well as 20 milligrams per kilogram. The velocities came down a bit better with the higher dose, but certainly for countries that are struggling to afford hydroxyurea, I think 10 milligrams of hydroxyurea in patients with an abnormal velocity is a very reasonable option, and indeed one even wonders whether it's more cost effective to consider hydroxyurea for every patient with sickle cell disease without doing a TCD. Now, has this made any difference? Well, on the left-hand side, you can see all the data that Ikiligunju from Ibadan and I could pull on the prevalence, the incidence of stroke, right back to the original POWERS data from 1965 to 1978, right through to Ikiligunju's data right up to 2019. And you can basically see that the incidence of stroke per 100 patient years is about 0.5. Yeah, it's about 0.5. ICI's data from Nigeria showed a much higher incidence of about 3 per 100 patient years of observation, but she brought that down with hydroxyurea to 0.5. And on the right, you can actually see the results of screening and treating. So I've included my data from London in between 1990 and 2000, and the Gunju's data from 2004 and 2012 in Nigeria, and then the untreated arm in Adam's data, where you can see that the strokes per 100 patient years are somewhere between 10 and 15, 10 and 15, and the Adams trial, 1995 to 1997, with current transfusion, brought that right down to about 1 per 100 strokes. 1 per 100 patient years of observation. But perhaps more usefully, the hydroxyurea has brought the incidence down just as well, and I think that it may well be that hydroxyurea becomes the medication of choice, but I think we do need more data before we think about that. So now there are protocols for doing transcranial Doppler. Ideally, we should be starting with 2-year-olds. I can do transcranial Doppler in a 2-year-old. I still do them at UCLH. They're tricky. You need somebody distracting, like you would do for testing hearing. I use the play leader, and I spend quite a lot of time before we do anything, letting the child relax and having a whirly, brightly colored toy or video, a child likes Peppa Pig or something like that. But we should, the incidence is quite high in this age group, and we should be restudying them, particularly if they're conditional in this age group. And then this is the guideline for 6 to 10 years. I'm going to share these slides. I would have shared them earlier, but I had a power cut, which slowed me down a bit. Okay, so I'm now about in the middle, and I just wondered if people would like to have a little bit of a thought about any questions so far, any comments, anything they'd like better explained. Even a comfort break.
Hi. Hello.
Hi, you're echoing a little bit.
Hello.
You're echoing. Do you want to put your question in the chat?
I think there must be a second connection near him or her, and if they can see that, okay.
So sorry for that. So my question regarding to the hydroxyurea and blood exchange for the patient. So it continue for 1 year or 4 years or lifelong in the practice.
Well, for if you are looking at secondary stroke prevention, the available evidence suggests that you should be transfusing for life or offering bone marrow transplantation or considering revascularization for moya moya. If you are looking after a patient with sickle cell disease and an abnormal transcranial Doppler velocity of over 200 a second in the USA or in the UK, or perhaps in Saudi Arabia, because I think you can use blood transfusion there, then I would probably think that in the current state of knowledge, you would use blood transfusion for a year and then consider switching to hydroxyurea. What I forgot to say is that if you are thinking of switching to hydroxyurea in that circumstance, on the Twitch criteria, Russell Ware's Twitch criteria, you should definitely do an MR angiogram then, because Twitch only applies to patients with a normal MR angiogram. And again, technically the transcranial Doppler is not measuring flow, and there are two reasons for having a high velocity. The first is that you've got very high flow related to the anemia, and the second is that you actually have a narrow blood vessel. For those of you who did physics A level, that's what the Doppler equation is about. Basically, velocity is related to flow, but the diameter is in the equation. So the MR angiogram then tells you if you've got a narrow vessel or not. That is actually a structural abnormality, and those patients are excluded from the Twitch criteria, and those patients should probably carry on with blood transfusion lifelong, or consider bone marrow transplantation, or even think about revascularization if the vessel becomes occluded. For the developing world, where blood transfusion is very difficult, and if you look at Dr. Lagunju's work from Ibadan, she tried very hard to persuade patients to have chronic transfusion, and she couldn't get any of her patients whose kids had high velocities. She couldn't get any of them to agree to chronic transfusion. I think that in terms of cost, in terms of risk of infection, the transfusion is extremely difficult, and the available data from the new spring trial suggests that hydroxyurea is a very reasonable option for primary prevention if the velocities are over 200 centimeters per second. Baba, do you want anything about that?
Thank you.
Okay, we've got a question from Mona as well.
Yeah, I completely agree with you. I think it's important, obviously, for just to emphasize the fact that I like your emphasis about the transition for life for the second stroke, particularly when you're able to do. And also, I think the emphasis about hydroxyurea utilization is important. And whenever you're using hydroxyurea as an alternative to blood transfusion, I think it's important to be able to offer the maximum tolerated dose, because that's the essence, that was the basis on which the Twitch trial reported. So making sure that you achieve at least one of the target, either a low retic or a low neutrophil, or I mean, so retic, platelet, or neutrophil are the three main ones that we look at. Any of them that is below the target, I think you need to do that, because the benefit of the hydroxyurea is achieved using maximum effect. So I agree with you, Fenella. Thank you.
Thank you. Anyone else want to disagree or have another idea? I did the GASCO meeting on Sunday, and somebody asked me about using anticoagulation, and I have anticoagulated a couple of patients with sickle cell disease who've had a venous sinus thrombosis, but I don't think there's any indication to do that for arterial stroke. One of the billion-dollar questions is for recurrent stroke in patients on transfusion, i.e. secondary prevention. If they're still having strokes, there is some experience with using aspirin, as you would do in the general pediatric population. I'm not advocating it, but I have been involved in making a decision to do that occasionally, and that is a very tricky situation. You should certainly be thinking about revascularization, potentially bone marrow transplantation, but as a holding measure, aspirin is a possible option. What the hematologists always worry about is the risk of hemorrhagic stroke, which is, you know, worrisome, but it's worth thinking about. Mona.
Yes, thank you so much for this interested lecture. I have question and comment. For the comment, I think TCD is very important to do it, and I wish it will be available in all hospitals, as we record zero stroke patient once we start this TCD screening. All the stroke patient, we got it from either outside hospital or all the patient before we applied the screening in our hospital. So I hope from this MOH project, TCD will be available in all the hospital, or at least to teach the general pediatric to refer the patient to the center which TCD is available. The question for you, from your experience, what's the indication to do a neurosurgical intervention as a for severe moyamoya disease, as it's for the patient not candidate for transplant or those with recurrent stroke? What's the indication to call neurosurgeon for intervention? Thank you so much.
Okay, so I think that's a very, very important question. I am a neurologist, and I have been interested in revascularization for many years, and I've been involved in revascularization at Great Ormond Street for 10 years. And it's also offered in Dr. Anousa's, Professor Anousa's department at Guy's and St. Thomas's. I think if you have a very good vascular surgeon and a patient who definitely has moya, particularly if they're having TIAs, but even if they're not, I think it is well worth referring for consideration of revascularization. The available data suggests that there's no greater risk of stroke in revascularization surgery in sickle cell disease than there is in the general population of children with moya. There appears to be a reduction in stroke risk longer term. We reviewed this carefully in the guidelines, the 2020 guidelines. There was a lot of debate about it, and I think the way it's worded is something along the lines of consider a referral, and I think some of the hematologists would prefer to refer for bone marrow transplant first, and there's a lot of debate about whether you do that first or revascularization first. The other thing I think is worth mentioning is that there's a little bit of data suggesting that hydroxyurea may actually reduce the collateralization after revascularization, and one of the papers that didn't find a benefit of revascularization, the patients were still on hydroxyurea, and so that you really need a multidisciplinary team, not just a neurosurgeon. You need a hematologist and pediatric neurologist with a lot of experience, and I think that each country should only really have one or two neurosurgical centers with a vascular surgeon who takes all the patients, or one or two vascular surgeons, but you do it in a single center or two centers in a country. Anybody else?
No.
Mona, is that you again?
Hi.
Your hand up.
Hear me?
Have you got another question, Mona?
Yeah, other Mona, I think she has a question. Other one.
Right.
Can you hear me? I'll ask my question.
Yeah.
You answer one comments. I was thinking about cerebral cause of acute head stimulation. So about pediatric, is it? And the second part, usually, and I meant usually risk of stroke is known to be more after after the recurrence of our patient. They spend like 3 years on vision, and after that the complication start, the line problem, and sometimes compliance for this I hydroxyurea would tolerate, and so to think about this. Thank you.
You're breaking up a bit there. Ola, did you hear that?
No, I thought it was my connection. I'm so sorry. Mona, it was very broken. We didn't really hear what you said. So if you could put it in the chat, that'd be great.
I think you were asking about hydroxyurea, I think I heard. Is that right?
This is was my condition. Yeah, after 2 to 3 years from as an alternative for trans.
Sorry, you were breaking up. I suppose if you're on your phone, you may not be able to put it. Yeah.
I think connection abroad. Hear me very well because I have problem.
Okay. If you can put it in the, I can answer it at the end of the session. Yeah. You happy with that? Anyone else? Okay. You happy for me to carry on? Yeah. Okay. So you might have noticed that I haven't mentioned silent infarction yet. And basically, I'm going to talk to you about the silent infarction, partly from the clinical point of view and partly from the research point of view, because this is actually the area of active research in London, and Professor Anusa is involved in it, and so most of the centres in London. We do recognise that people with sickle cell disease have silent infarctions. Let's make sure that I'm going to be able to. Yeah. Okay. So this has been picked up since we first started looking at imaging in people with sickle cell disease. In fact, Sally Davis, who was the head of the NHS in England and now is a Master of Trinity College, Cambridge, she's a sickle hematologist, and she did a CT scan study at Central Middlesex Hospital in the 1970s and could see that some patients had infarction on CT scan. And then as MRI became available, the cooperative study for sickle cell disease reported children with silent cerebral infarction on MRI scans. And then Michael de Bown has been particularly interested in this and organized studies to look at preventing further progression, and organized a randomized controlled trial. And perhaps most importantly, defined silent cerebral infarction as at least 3 millimeters in diameter, seen in 2 planes on a T2 weighted MRI, and or it could be a flare MRI. You can see that this 12-year-old boy with hemoglobin SS has got some areas of infarction, very small in the white matter on this MRI scan, and these are the silent infarcts. They are also seen in the elderly adult. In fact, the more you look, the more you realize that some even relatively young people have got a few. So they are there. As a neurologist, I would just say that some of them are not as silent as they might be. They might be silent to a hematologist, but the patient on the left has a very clear occipital lobe infarct and actually had a visual field defect. So I would very much like everybody to be doing a proper quick visual field assessment in every patient with sickle cell disease. All you need to do is hold your fingers up in your own visual field and just wiggle them and see whether the patient can see them. You can do it in children as young as 3, and then you need to do it in all 4 quadrants. So please do that, because then you won't look so silly when the MRI comes back and it wasn't silent after all. And then the patient on the right had actually had posterior reversible encephalopathy syndrome and was left with silent infarction. So and interestingly, in the Kinney study from 1997, which came from the cooperative study, one of the risk factors for silent infarction previous seizures, and some of those children with previous seizures had probably had PRES, and then we're left with silent infarctions. I'm going to keep wiggling my fingers to remind you to do the visual fields. Okay, so importantly, some patients with first few silent infarcts do have progression of silent infarcts, and this shows one of the patients from our study. Jamie Kawadler and I published these images in a chapter which is freely available. I didn't actually send this around, but if you type in Kawadler Kirkham 2016 in touch, it's a book that was edited by Professor Anusa, and we actually put quite a lot of information about MR imaging, which I don't have time to talk about extensively today. But basically, in the SIT trial, 12 out of 196 of the patients, or 6%, actually had progressive silent cerebral infarct. And interestingly, in the SIT trial, there wasn't any obvious reduction in the progression of silent infarction in the transfused arm. It's 5 of 99 transfused and 7 of 97 standard care. So that's not statistically significant. However, the important issue has been that there has been an apparent association between the silent infarcts and cognitive problems. So this is Jamie Kawadler meta-analysis from her PhD. She did her PhD with me and was a postdoc for a couple of years. And she looked at all the studies looking at full-scale IQ and MRI to distinguish silent infarcts and people with sickle cell disease in a normal MRI scan. And you can see that on the left-hand side, full-scale IQ is higher in the controls, and it's higher in the patients without silent infarcts than it is in the patients with silent infarcts. And you can see the silent infarct on the MRI below, and it's even lower in the stroke patients on the right-hand side. Been confirmed in 2 other meta-analyses, including the excellent, very comprehensive meta-analysis by Kmar Prussian, which was published in 2019. So the final results of the silent infarct transfusion trial, which Professor Anusa led in the UK, and we had 2 other sites in the UK. The final answer was that although the progression of the silent infarcts was not different in the 2 arms, the progression to overt stroke was statistically significantly different. In fact, actually, the predefined endpoint was recurrent infarct, not just recurrent progression or recurrent clinical infarct. It was recurrent infarct, which included progressive silent infarction as well as overt stroke. And this was statistically significant, and therefore, if you have a patient with silent infarct, you do have an option to transfuse patients because there is evidence from a randomized controlled trial. However, if you look at the data on the IQ, in the supplement to this, which very few people ever look at, because you have to scroll right down to the bottom of the HTML file, and most people just download the PDF, you will find that there was no difference in IQ after transfusion. Now, I could perhaps have said before they started, I wasn't involved in the design of the trial, although I did help with various aspects of it. But the key thing is that there's no difference in performance, verbal or full-scale IQ, and other domains of cognitive function, such as processing speed, working memory, executive function, which might have improved with transfusion for silent infarction, were not investigated in this trial. So if you have a patient with silent infarcts and they agree to be transfused and you want to transfuse them and you have the resources to transfuse them, there is some evidence, well, there is definitely evidence that you'll prevent stroke in those patients. And what I forgot to say about the CIT trial is that patients with conditional abnormal velocities were actually excluded. So this is another group of patients in whom prevention of overt stroke is feasible with chronic transfusion. And another worry about patients with sickle cell disease, which we're quite interested in, is the potential for progressive atrophy, particularly of the deep grey matter structures. And Jamie also looked at the CIT trial data and did not find a benefit of transfusing. In fact, if anything, the rate of atrophy was worse in the transfusion arm. But the most important thing is that there wasn't a difference. So transfusion doesn't seem to prevent progressive atrophy either. And further looking at the data on cognition in patients with silent infarct compared with patients without silent infarct, ignoring the patients with stroke, and looking at not just IQ, but looking at the domains of intelligence, which includes processing speed index, perceptual reasoning index, and working memory index. Mboka Jacob in Tanzania, who on scholarship to work with us, showed that there was no difference in children with silent infarct compared with controls and patients without silent infarct for perceptual reasoning and working memory, and also for the Raven's progressive matrices, which is a good test of intelligence, which doesn't rely on educational background, because as we were doing this in Tanzania, that was important. And there was a difference in processing speed index between silent infarct patients and the controls, but not between the patients with silent infarcts with sickle cell disease and those without silent infarcts in sickle cell disease. So that runs against the grain of the previous data, but the previous data mainly looked at full-scale IQ, and rather than breaking the domains down. The other thing that I think it's probably important for you to recognize is that in this study, we're presenting the mean difference from controls, and we have taken out of the equation whether there's any difference from standardized tests, because these children in Tanzania don't necessarily have the educational background that you would get in the United States, where the Wechsler scales were originally standardized. So we've just reported the mean differences and not the actual scores. Okay, so I'm setting myself up to say that now we have 3 Tesla magnets, and I suspect that many of you have 3 Tesla magnets. We have been looking even more closely, and this is Hannah Stotesbury and Professor Nusa and a lot of the rest of the UK team have allowed us to examine their patients. And Hannah looked not only at the CIT trial definition, which is the recommended on the right, sorry, the traditional in the middle, a traditional SCI in the middle of this, but also at a liberal definition, which has also been used by the Dutch group particularly, where they've really called everything white matter hyperintensity, which is actually what the literature in the elderly adults has looked at. Rather than looking just at those over 3 millimeters, anything that's a white matter hyperintensity counts. And then there's also a restrictive definition, which has also been used in the elderly adults, where you also have to have a T1 abnormality as well as a T2 abnormality. And that's actually what was used in Baczynski's study in adults. Anyway, Hannah did a massive amount of work for her PhD, which I'm delighted to say she got with absolutely no corrections at the end of last year. She's just publishing this in Frontiers in Neurology. But the bottom line is we can't see any cognitive difference across any of the definitions for full-scale IQ, working memory index, or processing speed index. And in fact, quite a lot at 3 Tesla, which it basically the field strength of the magnet is higher. So you're seeing more, basically, you're seeing less noise and more signal. And there are quite a lot of controls with silent infarcts as well. So the harder you look for the silent infarcts, the less there's an easy association with full-scale IQ, working memory, or processing speed. I don't think that my hematology colleagues are very pleased with this, because I think you will like looking at something on the scan that you can say that it's definitely abnormal and therefore you need to do something. I'm really sorry about that. We didn't intend to set off to do this, but actually we really can't see this. And we reviewed all of the recent literature at 3 Tesla, and there's only one paper that actually did find an association with cognition. One of the Dutch papers does a higher field strength did show an association with cognition with white matter hyperintensities. So I do think we need to think about what we would want to do to basically improve cognitive function in sickle cell disease. I've already mentioned processing speed, and there are a couple of tests on the Wechsler scales that do this. One is coding, where you basically have a series and you basically have to put each of these symbols in the coding box, and you have to do it quickly. Another is symbol search, and I'll be talking a little bit later about a really easy pencil and paper test called cancellation, and also about the NIH toolbox. But there is some sense in doing this, because these tests are relatively quick to do, and Hannah's data, she published this in 2018, showed that patients with sickle cell disease had a lower processing speed index than controls by 9.34 points, and that was regardless of whether they had silent infarcts or not. But the really important thing is that the trend for lower full-scale IQ was abolished when processing speed was included as a covariate, which suggests that if you have sickle cell disease then you do things just like everybody else, but a little bit slower. And that's actually similar to some data that Alex Hogan and I had from studies in Bolivia at altitude about 10 years ago. So this may be related to being anemic, being a bit hypoxic, and being a bit slower, but actually getting things done a little bit slower. I'm not going to talk very much about complex MRI, but just to say that I think we're now moving beyond the silent infarct to look at quantitative MRI. And Hannah did a nice study looking at white matter integrity with a measure called fractional hypertrophy. And she showed that processing index was related to to the fractional anisotropy, and that correlation remained significant both SCI and plus and SCI negative patients separately. And Jamie, in a previous paper in 2015, had also shown that the fractional anisotropy measure was related to oxygen saturation. So we think that actually processing speed, how quickly you do something, is probably related to how well myelinated your white matter is. That starts in early childhood and progresses. And obviously, if you have problems with ischemia, particularly if you've got silent infarction, then the myelin may well be damaged, and you may well therefore be thinking a bit slower, still able to do it, but a little bit slower, because so the link to white matter abnormality probably makes some sort of sense. It's early days, but to my mind, simple mind, it makes some sort of sense. And others have been interested in this as well, and this is data from the Toronto group, which shows that patients with sickle cell disease who are on hydroxyurea actually have white matter integrity measured, in fact, as kurtosis. Don't worry about what that means, but basically the controls, basically the patients who are on hydroxyurea have white matter integrity much more like controls than patients who have sickle cell disease and are not on hydroxyurea, again suggesting that white matter integrity might be a reasonable endpoint for looking at whether treatment helps the brain as well as the pain. So when does this problem with the processing speed and the white matter start? Well, we don't know for sure, but Michelle Downs, who worked with us, showed in preschool children that there was relatively intact processing speed, and the processing speed is in blue, and inhibitory control, which is another NIH toolbox test that she used. They were relatively well preserved in preschool children, not even for the controls, not quite the average for the rest of the population, but pretty good. And the children with sickle cell disease were not significantly different, a little bit lower, but not significantly. So is there a decline? Well, there's not very much data on this. The Wang paper from the cooperative study followed up a lot of the children with sickle cell disease who had an IQ in the 1970s and 80s, followed them up in the 1980s and 90s. They had central overread of the MRI, but the field strengths were sometimes quite low. They were as low as 0.5 Tesla, and a lot of them were at 1 Tesla, and some of them were at 1.5 Tesla. They defined silent infarct as an abnormal T2 rated signal intensity, but they didn't have the 3 millimeter rule that was used for the silent infarct transfusion trial. And the other problem with this study is that they did change from a previous version of the Wechsler scale to the WISC-3. However, despite the difficulties, they did show very clearly a reduction in verbal IQ of 0.5 IQ points per year, coding, which is one of those processing speed tests, of 0.2 points a year, and maths, really worryingly, because you really need your maths as an adult, 0.9 points per year. But there was no deterioration in either digit span or reading. So that's the cooperative study. We have data from London, the East London cohort, and we had a 74% retention rate. We did, all our scans were done at 1.5 Tesla. Interestingly, we actually saw improvement in scores in the controls, the blue line. That's called the Flynn effect, and is partly probably related to education and probably related to having seen the tests before, and there's a bit of a practice effect. the children with sickle cell disease, either with or without lesions, they're called here, or silent infarcts, actually did not deteriorate in our data significantly, but they didn't show the improvement that the patients with that the controls had shown. And it's only in this data set, it's only the children with symptomatic stroke. That includes the patients with moya, and Alex Hogan, who did this work, actually published a paper on moya and sickle cell disease at the same time, and showed significant deterioration in moya disease, which is another reason why I'm quite keen on revascularization. So some evidence that things are not going quite so well, but no evidence in this data set of an effect of silent infarct. Although what I forgot to say about the Wang data is that they saw that the situation was worse for the patients with silent infarct. And this is brand new data, which I think is probably going to get published in British Journal of Haematology, one more round of reviewers. This is Mary Ann Poma's data from Ghana, which she used for her master's and then for her PhD, and she had 7-year follow-up for adults with sickle cell disease. Again, not using the Wechsler scales for IQ, but using a different test which has been validated in Ghana, the RQ-CST, and also looking at a trail making test, which is a test of processing speed, and at sorting, which is a test of executive function, as well as digit symbol substitution, and a couple of other tests from the Wechsler scales for adults, the WACE, and also a tricky test that I can't do. I can do the Ravens. I scored 12 in the Ravens, which is a top score. I can't do the Ray Osterreich. It's a horrid figure that you have to reproduce exactly as it is, copying it initially and then doing it from memory. Anyway, bottom line is that the tests that are in red were worse after 7 years in the patients with sickle cell disease. So some evidence for processing speed problems, some evidence for difficulties with executive function, with increase in perseveration, and some difficulties with the Ray Osterreich figure as well. So some evidence for deterioration in adults. This is the first time anyone's ever managed to show this in adults. So I mean, all credit to Mary on her own, with a little bit of help from Kofi Annie in the UK and from Charles Jones Saint in the States, and a little bit of help from me. We've managed to get it, we think, to publication. So there is some evidence for decline, maybe with time. Not, I mean, Mary doesn't have data on MRI, so we don't know whether silent infarct is important in the adults. We don't see that in the children in London. Is the whole thing a decline, or is there a difference in trajectory? And Mboka's data from Tanzania suggests that actually there may be a slower acquisition of processing speed skills in children with sickle cell disease. This is not longitudinal data, this is cross-sectional data by age, but the trajectory for coding, symbol search and cancellation, those 3 processing speed tests, and for picture concept, suggest that the trajectory is slower in children with sickle cell disease. Again, maybe because there's compromise of the white matter from a relatively early age, which then continues. And Melanie Colville, who I'll discuss some of her work in a minute, she's got similar data in the London cohort, and we're just pulling that together. Can we do anything about the cognitive side, treatment-wise? Well, Anna Hood, who was my postdoc for a couple of years now in Manchester, did a very nice study when she was doing her PhD at Washington University in St. Louis, looking at patients who were in the silent infarct transfusion trial, and she looked at them just immediately after transfusion first and then just before transfusion. And she did executive tests and processing speed from the NIH toolbox. And she found that that basically the executive tasks improved near transfusion and were better than hydroxyurea and declined away from transfusion, and that was worse than being on hydroxyurea all the time. And the change in hemoglobin was significantly related to the change in executive function in patients receiving transfusion. She also looked at processing speed with pattern comparison and found a practice effect for children with sickle cell disease and controls. And practice effect, I think, is something that if we're going to be looking at cognitive outcomes, if we want to look at treatment, I think there's something we're really going to have to think about very carefully. Okay, so what else? Bone marrow transplant actually doesn't improve full-scale IQ any more than transfusion does for people with silent infarcts. But actually, it does look as though it does improve processing speed, and this is pooled data that came up Prescient published last year. And basically there is increase in processing speed index in patients with sickle cell disease undergoing bone marrow transplant. That's the sort of current thought. That what I forgot to say is that there is a good paper from Win Wang's group suggesting that hydroxyurea does have a benefit in terms of improvement in some cognitive tests, but not all. We've also been interested in sleep because we had access to the sleep asthma cohort data. And this is Melanie's work. She's just submitted her PhD looking at coding and total sleep time during inpatient polysomnography. With the inpatient polysomnography was done between 2010 and 2014, and the cognitive tests were done in 2018, so a little bit of time between the two. But you can see here that your coding was better the longer you slept. And interestingly, there's been quite a lot of this on the UK radio recently. We're all supposed to have about 7 hours sleep. Skipping sleep is not good. And as somebody in the elderly adult category, I am definitely making sure I get my sleep. I would strongly recommend that you do, and that you make sure your patients are. Melanie actually found in the UK that a lot of patients with sickle cell disease were not getting a full night's sleep, and she did publish that last year. The test that I really like for processing speed is actually this really simple test. If you're an adult, you do it with letters, so you might be cancelling all the E's. If you're a child, you do it with animals, and you're looking for all the whatever cows, and you basically just have a sheet of paper and you cancel as many as you can, and the psychologist tots that all up. Really simple. And we did a study about 10 years ago where we did a pilot trial of overnight auto-adjusting positive airway pressure, because I am interested in sleep, and I'm interested in the fact that patients with sickle cell disease do drop their oxygen saturations during sleep. So we were able to do auto-adjusting positive airways pressure, or CPAP basically, but auto-adjusting. With children would wear a mask. This is a 6-week study, and they did manage it for 6 weeks. On the left is the processing speed, which is a combination of symbol search and coding, and there was definitely a practice effect there over a 6-week period. The patients with the CPAP and the controls both improved, whereas with the cancellation, the patients with the CPAP improved, and the patients randomized to standard care did not. This was published in Hematologica about 2011, I think. So we actually went on to do a larger trial, phase 2/3, and again we did actually we didn't have anything statistically significant, but we did actually have data suggesting that cancellation improves a bit better in those on the APAP, and that was particularly true for those who were already using hydroxyurea. So a combination of hydroxyurea and APAP to avoid those desaturations does seem to be a benefit in terms of processing measured by cancellation. And what the problem with CPAP is that is the compliance, and what we found was that APAP used the night before was associated with an improvement in cancellation, whereas if from the intention to treat point of view, that it favors CPAP, but not statistically significantly. What else might we be able to do? Well, going back to those young children, we had sleep study data in some of the patients that Michelle studied. Now, these are small numbers, only 10 patients, and 7 did not have obstructive sleep apnea and 3 did. But interestingly, the coding and the processing speed on the NIH toolbox were both worse in the 3 patients with obstructive sleep apnea. And this is a preschool population aged 3 to 6 years, so really very young children. And Lucy Brennan, who's a student with me, did a nice study looking at tonsil and adenoid size in children with sickle cell disease, and found that basically tonsils and adenoids were quite a lot larger. Sorry, the the tonsil and adenoids are larger, and the width of the nasopharynx is lower in the children with obstructive sleep apnea on a polysomnogram. This may, because you get a scalp view like this for free in an MRI scan, even if a child leaps off the table as soon as you start, you've almost certainly got a scalp view, and this might be quite a quick and cheap way of actually deciding who is at risk of obstructing their airway at night if it's narrower. But we need to do some more work on this. What we are going to do now is to do a randomized trial of montelukast in children with sickle cell disease, randomizing preschool children to montelukast, which in the general pediatric population with large tonsils and adenoids does shrink them. So that's been shown by the Gozar group in the States. We're randomizing to montelukast or placebo, and the follow-up, the endpoint is NIH toolbox processing speed, and also cancellation. I put the cancellation back in after I realized that Anna's data also showed the practice effect. So we're also going to look at an executive composite as well. And we're starting that this summer, and several of my American colleagues are also quite interested in this, and anyone else who's interested, please contact me. The protocol was actually published last year in the journal Trials. So just to summarize, prevention of neurological complications. All stroke syndromes are seen in sickle cell disease. What you really want to do is to prevent them all happening, because the recurrence risk is high despite transfusion. So you really don't want that first stroke to happen. Children with sickle cell disease should be treated as any child with a stroke. And in the UK, any child with a stroke gets a full protocol workup with an MRI, an MRA, and an echocardiogram. And in fact, I haven't had time to discuss that, but there is some evidence that although overt stroke is rarely related to emboli from the systemic circulation, it does happen. And Dr. Nusa and I will remember a patient that he asked me to see who'd actually got pelvic vein thrombosis and had an embolic event from that. So it does happen, but it's not as common as vasculopathy involving the middle cerebral artery and internal carotid artery. So children who've had a stroke should have a full workup, because then you can think about how you're going to prevent recurrence, not just with transfusion. It is pretty clear now that primary prevention with TCD screening and either chronic transfusion or hydroxyurea at a dose of more than 10 milligrams per kilogram does prevent stroke and sickle cell disease, almost certainly by reducing the flow in the middle cerebral artery so that you don't get the permanent stenosis or occlusion in that internal carotid and middle cerebral artery scenario. Doesn't prevent all the strokes, and the strokes that I continue to see are hemorrhagic or related to posterior reversible encephalopathy syndrome or venous sinus thrombosis, things that you couldn't prevent with TCD screening. But if you've got a good TCD screening program, arterial ischemic stroke is now preventable in children. There is a problem that you don't get the high velocities in adults. You probably get more neck vessel disease, and so the TCD screening program stops at 16 and doesn't help the adult, and there are very few data in adults at all, and so that's a very big black hole. There is cognitive compromise in patients with sickle cell disease, particularly if they have an overt stroke, and probably if they have a covert stroke as well, although more recent data at higher field strength magnet does suggest that's not always the case. And we don't yet know quite what to do about that. My personal view is that research should probably be concentrating on processing speed and looking at treatments which might prevent cognitive decline, and also perhaps encourage a normal trajectory from as early an age as possible. And treatments might include blood transfusion, probably not for silent infarcts, and it's a very heavy burden. But I think the data are going to be coming in on the effect of hydroxyurea from infancy. 9 months is the current recommendation from the US, and I think the data are going to be coming in on the use of hydroxyurea and cognition in sickle cell disease. And then I think we should all be sleeping better. I'm certainly making an effort because I don't want to stroke at my age, and we don't want the kids to be having a stroke either, and that may well act directly. There's a lot of considerable interest in the role of sleep in preventing accumulation of tau protein in Alzheimer's. We don't know whether that's a mechanism in sickle cell disease, but importantly, high blood pressure is certainly a risk factor for stroke and silent infarction in sickle cell disease, and better sleep probably does bring blood pressure down as well. And I'm just going to leave you with my my stroke for hematologists and non-neurologists. This is something I did originally for the European Hemoglobinopathy Association. It just has the stroke syndromes. It's not easy even if you're used to doing it, to work out what a child in front of you with a seizure, an acute headache, or a hemiplegia is actually, what exactly has happened and what you need to do about it. And of course, the most important thing in stroke in any age is that time is brain. So you've got to work out really, really quickly what to do about this. And this is just a simple guide to what might be wrong and what you might do about it, and who you might need, including intensive care and a neurosurgeon. So thank you very much for asking me. Happy to take some more questions. And I can see the chat has got 5 things in it, so maybe there's a question. think I'm supposed to be looking at Slido. I'll stop sharing. Not sure where the Slido is. Okay, so the question that we were being asked after the last session from Mona about it was basically about the use of hydroxyurea after 3 years of stroke. If you're having a lot of complications, transfusion. Personally, I think that if you've got a lot of problems with transfusion, it is worth considering hydroxyurea after 3 years. And I think if I would strongly recommend that you also involve the neurologist in case there might be something else that might be helpful, including revascularization or possibly aspirin or bone marrow transplantation. But we have had a patient in London where it was impossible to transfuse, and they did go on to hydroxyurea.
Sorry, can I comment on that, please?
Sorry?
Hello? Can
Yeah.
I comment on that? Because studies show clearly, even after not 3 years, even after 10 years, if you stop transfusion, the risk of stroke, recurrent stroke is high. So I think the optimum thing, if you cannot transfuse, you should go for bone marrow transplant. Hydroxyurea will not help much in these cases. Thank you.
Okay, well, I'm happy with that. Anybody else?
Anyone have question? Okay, thank you, Professor Fenella, for your presentation.
Okay. Nice
And if anyone have question, please write it on the link that I have sent to you on Slido. And see you on Thursday. Thank you so much, Professor.
Okay, bye-bye.
Thank you, bye.
Thank you, Ola.